This can be done to the T-spine. It could be done to the L-spine. This could also be done to the ribs. So yes, again, this is an L-spine type of presentation we're doing, but if it's a mob that applies everywhere, let's look at it everywhere. And this was our iliocostal mobilization. So with this iliocostal mobilization, what I'm doing here is I'm going to create this kind of counter rotation with the pelvis. I'm doing this movement, and that's going to cause my TVPs to rotate in this direction, and they're going to move in a more posterior orientation, which gives me some room to mobilize them anteriorly, right? That's where the true part of the mob is coming from. If I was to just straight compress through here without having that pelvic rotation, you're not going to feel this at the spinal segment. You probably won't, unless the person that you're mobilizing, you can see through their ribs from across the street, but most of us aren't that lean. So in that case, if I was to compress straight through here without that pelvic rotation, you might not feel it, or the patient might not feel it the way you want them to. And with this mobilization, like I said, I'm going to go here, ASIS. I'm going to rotate that ASIS. Now I'm going transverse processes, contralateral side, opposite side. I can use single points of contact. I can use my pisiform right there. If I wanted a single point of contact, just palpate and drop it through. If I want a more broad point of contact, I'm going to use my thenars. And then from here, here's my mobilization, a straight anterior movement while I hold this into that pelvic rotation position. And then again, if you wanted to, and you're hardcore about grades and what the grades do, and that's a firm part of your practice, cool, then working with those. If you're like, dude, I don't buy all that stuff, maybe that doesn't make sense, then it doesn't change the fact that this is going to be an awesome movement to do at the spinal segments, and it might bring some calming down for your patient, and it might bring just a feel-good sensation as well, and it might bring the movement changes that you're looking to have. Now, when you get into the L-spine, like we said yesterday, well, it gets a little tight in here because obviously we have a smaller area. We've only got 5 segments, at least most of us, unless we have some anatomical anomaly, which some people do. But nonetheless, it's still a small area to be in. And then we have this lordotic curve. So getting your whole hand in here can be problematic, right? We've all treated that person where you're like, why is it your ilium is so high to your 12th rib? You're like, I can't even get my hand in there. So in that case, I might be using a little bit more of my ulnar contact. It's the same idea. There's my rotation, and there's my glide, anterior glide through. Like I said, yes, I recognize we're talking L-spine, but this is a mobilization that can be used all over the body, and therefore it can also be used for the ribs. And this is a great mobilization for the ribs. We're creating the same pelvic rotation right here, which is going to cause the ribs to rotate on this side more posteriorly, which is going to give me that space to push that guy through. So in this case here, instead of lining up on the TVPs, I'm going to be on the posterior aspect of the ribs close to the angle. I can set this up a single rib with an ulnar surface contact. And again, whatever contact surfaces you want to use, whatever's comfortable for your patient, and whatever you can use to get the job done. To me, that's the most important thing. Then are you using the ulnar border of your hand? And then from here, I'm going to be on the lateral aspect. I'm going to do the posterior aspect of the rib close to the ankle. Here's my movement, and then I'm going to send the rib straight anterior. And I can do this for several ribs at one time if I wanted to, general rib mobility. When you're doing this mobilization, that patient probably will not talk to you about the sensation of the compression over the posterior lateral side of the ribs. They will more so talk to you about the sensation of the mobilization at the costovertebral joints. That's where they're going to feel it. It's not a massive rotation here. I'm not pulling this up and rolling her off the table. I want enough just to create that counter rotation that I've got something to play into. I'm going to palpate TVPs, right? Spinous process, move out lateral. TVPs, in this case, I'm using palmar surface, palpating my ASIS, give this a gentle twist, and then from here, it's a straight down movement. Straight down movement. In this case, I'm oscillating through. Can you sustain the mobilization? Absolutely, right? Go with what feels better for your patient or your client. Go with what's working for you in the moment. Into the lumbar. We can also take this out into the ribs. So in this case, I might do this over one rib, palpate that, and send that rib anteriorly, or I can do it over several. And if I were to ask Amanda, where does she feel this? She would most likely tell me she feels that right along there. Cool. All right.